Right, so welcome to this webinar presented by the Deanery Faculty of Health Sciences here at University of Cape Town in association with the South Africa HIV Addiction Technology Transfer Center. We're really happy you could join us today. This is the outline of how today will go. We'll have the presentations by Prof Bronwyn Myers, Prof David Marsh, followed by that of Dr. Teresa Marsh. You'll find a handout of Dr. Marsh's presentation in the control panel to your right. If you registered before 2:15 today, you will have received a copy of the presentation. Otherwise, we'll send it to you after the presentations are done. The panel screen may seem to disappear when you open the attachment to view the handout. And if that happens, just toggle between the two and you should be fine. Please don't hesitate to post any thoughts or questions in the chat pane, and feel free as well to post any questions to the panel using the question pane in the control panel. And we obviously won't get to all of the questions. We'll do our best to do so, but we plan to circulate a follow-up communication responding to as many of those comments and questions as possible. You'll also receive an evaluation form after this webinar is concluded. Please be so kind as to complete it for us. Additionally, a recording of this event will be made available after a couple of days so that you may revisit what we've discussed. Our first speaker today is going to be Professor Bronwyn Myers. Bronwyn Myers is a chief specialist scientist in the Alcohol, Tobacco and Other Drug Research Unit of the South African Medical Research Council, where she leads the intervention research substream with a special interest in effectiveness studies and implementation science. She is an honorary appointment here at the University of Cape Town's Department of Psychiatry and Mental Health. She has over 15 years of research experience enhancing access to quality services for people with substance use disorders and co-occurring mental and physical disorders. She's funded through NIH, the British Medical Research Council, and the Wellcome Trust. And she's published extensively on the topics of mental health and substance use disorders, vulnerable populations, and provision of evidence-based practice. So what you'll view now is a presentation by Prof. Bronwyn Myers, and I hope you enjoy.
Thank you for the opportunity to participate in today's webinar. Today, I'm going to be setting the scene. I'll be talking about substance use disorders in South Africa and the impact that COVID-19 has had on substance use service delivery and potential ways that we can respond to this challenge. Substance use disorders are highly prevalent in South Africa. Findings from the most recent nationally representative survey indicate that almost 6% of the South African population meet criteria for a 12-month diagnosis, which is significantly higher than the 2.6%, which is the global estimate. Yet only 2 to 3% of individuals who meet criteria and perceive a need for treatment are able to access minimally adequate treatment for substance use disorders. This highlights the extent of the treatment gap for substance use disorders in the country. In addition, there are many South Africans who drink alcohol at hazardous and harmful levels, yet do not meet criteria for a substance use disorder. South Africa is a nation of heavy drinkers. On average, people who drink consume about 30 liters of absolute alcohol per year, which is significantly higher than the global average. The patterns in which we consume alcohol are also problematic. 59% of drinkers are heavy episodic drinkers, drinking 5 or more drinks on one occasion, and 65% of drinkers aged 15 to 19 are heavy episodic drinkers. And this pattern of drinking is associated with the increased risk for injury and health-related problems. In fact, this pattern of drinking has a significant impact on South Africa's burden of disease. Alcohol is the top risk factor for disease burden amongst adults aged 15 to 49, and most of this is attributable to alcohol's impact on both intentional and unintentional injury. The ideal substance use care pathway would include a stepped care approach in which there are low-intensity interventions are available in community settings where individuals with substance use problems may be screened and detected. And for those individuals who do not respond to these low-intensity interventions, they will be referred to more intensive services in a stepped-up approach. Irrespective of where a person enters the system, continuing care services in the form of support groups and aftercare services would be available to prevent relapse and to support recovery. And for individuals who do not have access to these services or who do not respond to intensive services, there would be harm reduction services available to limit the health and social consequences of continued use. In South Africa, the extent to which the complete care pathway exists varies from province to province. Even in well-resourced provinces that have most aspects of the care pathway, some aspects function better than others. Many of the gaps relate to the poor integration and lack of coordination of services between the Department of Health and the Department of Social Development. The Department of Social Development is the main department responsible for the delivery of substance abuse treatment services. The Department of Health is responsible for the delivery of mental health services, as well as medical detoxification and medication-assisted treatment for substance use disorders. Major gaps in the care pathway include limited availability of continuing care services, limited availability of screening and brief interventions in primary health and other secondary and tertiary healthcare facilities, very limited availability of medical detoxification and medication-assisted treatments, particularly in outpatient and inpatient specialized substance abuse treatment services, and the limited availability of harm reduction services in general, apart from a few demonstration projects that are not available at scale. COVID-19 restrictions on alcohol and movement and stay-at-home orders have highlighted gaps in the substance use service system. The vulnerable have been most affected. Individuals who are homeless and use substances have been provided with shelter, but also forced into sobriety without psychosocial interventions or medication-assisted treatment. As such, the sobriety is unlikely to stick, and they face a risk, if they are opiate users, of increased risk of overdose and death when they return to substance use. We've seen alcohol restrictions under lockdown levels 4 and 5, which have had a very positive effect on the number of trauma cases in the healthcare system and provided the healthcare system with an opportunity to prepare for COVID-19 cases. But the easing of the restrictions has shown that decreased alcohol use has really been short-lived. We've seen long queues outside bottle stores that people have stocked up on alcohol, and they seem to be making up for lost drinking time by consuming even more alcohol than usual. And with this, we've seen an upsurge in alcohol-related trauma cases, with 60% of the trauma cases in the Western Cape being alcohol-related. This would have been an ideal opportunity to provide alcohol-related harm reduction interventions within emergency departments and trauma unit settings, but unfortunately, these were defunded. What has the impact been on COVID-19 on the provision of substance use services? We've surveyed substance abuse treatment providers and asked them about the impact on service delivery. And they have highlighted 5 key areas where services have been impacted. First of all, they have treatment admissions have been paused, and for the most part, they're not seeing new clients. So there's a growing waiting list, and individuals, despite decreased access to alcohol and other substances in communities, there is no treatment available for individuals who may wish to access services. There's also access become restricted for existing clients. Some services have paused in-person or face-to-face services and have tried to move their services to telephonic provision or online provision, but there are structural and systemic barriers for individuals accessing these services. Access to the internet and issues around privacy are key concerns. Medical detoxification in the healthcare system has become more and more difficult to access because most health services are focused on preparation for the COVID response, and this is not seen as a priority service. Facilities that are operational have also pared down their basket of services to promote social distancing, so many of the groups that are essential for effective service delivery, notably the therapeutic groups, the continuing care and aftercare support groups, and family groups, have either been paused or some services are trying to provide them online. But again, this is an issue of access, particularly for the most vulnerable and needy. And then services are concerned about people in recovery. They are seeing more and more of their clients expressing vulnerability for relapse, particularly because of triggers and mental health concerns related to COVID, anxiety, depression, and boredom. Despite the negative effects that COVID-19 has had on substance use service delivery, it also presents an opportunity to reconfigure the substance use treatment system in order to enhance its accountability and effectiveness. The public focus on substance use disorders has never been greater, with the public debate around alcohol and tobacco. The easing of alcohol restrictions and the impact that this has had on levels of gender-based violence, crime, and alcohol-related injury and the trauma system has highlighted the consequences of an inadequate response to substance use on public health and society. And this represents opportunities to advocate for greater investment, both human and financial investment, in services for substance use disorders, and an opportunity to reconfigure the treatment infrastructure so that it is more responsive to the needs of people who use drugs and their communities.
Thank you very much to Bronwyn for that and for really just providing us with the lie of the land in terms of what the situation is in South Africa. And certainly it bears thinking in terms of, what was the impact really of the lockdown on folks who are the most vulnerable. And when you speak about reorientating the health system, how do we really take advantage of this opportunity that we have right now to reorientate? And how do we make sure that we're aligning with what the real sort of priorities are in the ground? And this is where Prof Marsh's talk is going to be really, it's going to help us think through some of this in terms of where does sort of social accountability fit? What is social accountability? How does it apply to our context? And so we are very pleased to have Prof Marsh with us. Prof Marsh will begin by providing an introduction for himself in a moment. And in addition to that, what's worth noting is that Prof Marsh is an author of over 140 peer-reviewed papers, book chapters, and governmental reports. His research interests have focused on treatment of opioid dependence, and he's received the Nice Wonder Dole Award for American Association for Treatment of Opioid Dependence and fellowships from the International and American Societies of Addiction Medicine in recognition of his contribution to the field. So, Prof Marsh, we thank you for joining us, and we look forward to your talk.
Good afternoon, everyone. My name is Dr. David Marsh. I'm a professor of clinical sciences and Associate Dean, Research, Innovation, and International Relations at the Northern Ontario School of Medicine. I've been an addiction medicine physician for over 25 years and have previously practiced in Toronto and Vancouver, where I had faculty appointments at the universities there. I'm going to talk to you today about social accountability, what that means for the Northern Ontario School of Medicine, and opioid agonist treatment, research around that treatment, and how we use that research as an example of responding to the needs of the communities that we serve in Northern Ontario. And finally, I'm going to close with a few comments about the impact of the COVID-19 pandemic on the opiate use disorder patients in our area. I have no funding from pharmaceutical companies or other medical device companies for my research or personal income. I don't do consulting with them. I'm not on any advisory boards. I do have a salary from the Canadian Addiction Treatment Centre as the Chief Medical Director, where my role is to drive forward quality of care. And I have a salary as the Associate Dean Research, Innovation and International Relations at NOSM. This is a map of Canada. It shows Ontario in the center here, which is the most populated province in the country. About 11 million out of the 33 million people in Canada live in Ontario. The vast majority live down along the Great Lakes here around Toronto in the area called the Golden Horseshoe. The two red dots are Sudbury and Thunder Bay, the locations of the two universities for which NOSM is the Faculty of Medicine. This map of Ontario gives you a sense of the population density. You can see it's very heavily populated down here around Toronto. And in the 800,000 square kilometers of Northern Ontario, which is the region served by NOSM, there's a little bit less than 0.4 people per square kilometer over most of this terrain. There's 800,000 people in 800,000 square kilometers. So there's some population density around Sudbury and Thunder Bay, Sault Ste. Marie, Timmins, and North Bay, the main cities, the largest of which is Sudbury, with 165,000. But most of the geography is very sparsely populated. And the people living in these areas have less access to health care and poorer health outcomes compared to the majority of the Ontario population living in the dense urban areas in Southern Ontario. The Northern Ontario School of Medicine was formed in the beginning of this century and opened in September of 2005. Unique amongst medical schools in Canada, we are the Faculty of Medicine for two different universities, Laurentian University in Sudbury and Lakehead University in Thunder Bay. And our school was created with an explicit social accountability mandate and a clear commitment to innovation and academic freedom. Social accountability for us means the obligation of the medical school to direct our education, research, and service activities towards the priority health concerns of the people that we serve. For us, that's the people in Northern Ontario. And to identify those priorities in partnership with communities. We try and do this in a way that specifically targets the disempowered members of the population that we serve in order to empower them relative to their fellow citizens within the area. So Charles Bolin, who had written the WHO definition of social accountability in 1995, has described this partnership pentagram where the priority health needs of the population are jointly determined between the members of the community, the academic institutions like the universities and the medical school, health professionals, physicians, nurses, and their professional organizations, policymakers, government, or other areas, and the health managers, the people who run the local health networks and hospitals and services. Each of these corners of the pentagram are equally important. And as I said, when we engage with the community, we try and specifically engage with disempowered members of the community for whom health outcomes are worse So we have specific efforts to reach out to Indigenous, Francophone, and rural populations who have poor access to health care, worse health outcomes, and therefore are higher priorities for us to actively engage and empower through our medical education, research, and service. NASM has developed a distributed community engaged model of education. Our activities are widely spread over 90 different teaching sites. We try and develop and deliver our educational activities in a way that's independent of time and place, and that recognizes community partners as active partners in the design and delivery of education, research, and service. This map of Ontario shows all the different sites where we have learners in the last academic year and the different types of learners. So we have medical students, residents in different residency streams. And the residency programs that we run are picked to be areas where there's a particular need for those types of physicians in Northern Ontario. Family physicians, general internists, general surgeons, obstetricians, psychiatrists, and so forth. And then we also have physician assistants, other health science learners, dietetic interns, and so forth, to try and address the gaps within the health human resource settings of Northern Ontario. And those different types of learners are spread out in many different urban and rural sites across the whole geography of Northern Ontario. As I said, the communities are active partners. It's an interdependent partnership, and we try and run our activities in such a way that is mutually beneficial for the healthcare system, for the educational activities, and for the community members. Community members work to ensure that students feel at home when they're living and learning in their community. We think that's a predictor of recruitment and retention in those rural areas once the trainees have finished their training and entered independent practice. We think it also contributes to the students' learning experience. We build curricular material around social determinants of health into the curriculum throughout all the training programs. And by really living and being a part of the community while they're there, we have a better understanding of the social determinants of health in those communities. Finally, we think that for social accountability, a real key is demonstrating an impact on the health of the communities that we serve. And so I'm going to move now to talking about one specific health area that's high impact on the population of Northern Ontario and some of the research that we're doing to help improve quality of care in that area. So you've probably heard about the opioid crisis that's going on in North America, Canada, and the US, escalating over the last 15 to 20 years exponentially, overdose deaths related to opioids. And Ontario has been heavily hit by that, in Northern Ontario in particular. And there have been several efforts by federal and provincial governments to try and respond to the shifting face of this opioid epidemic and public health crisis related to overdose deaths. One of the factors driving this escalation in opioid use disorder and overdose deaths is the increasing availability of opioids. You can see from this graph that going back to 1980, milligrams equivalent of morphine per capita prescribed in Canada has been exponentially increasing. Depending on which measurement you use, we're either first or second with the US in total per capita opioid prescribing. Of course, this doesn't account for the illicit market opioid availability. And this graph does stop at 2014. If we included the last 5 years, you would see some flattening of this curve and perhaps starting to decrease as there have been many measures brought in to try and improve opioid prescribing by physicians. I will note that on all these measures of prescribing, Northern Ontario, Ontario had higher prescribing than most other provinces, and Northern Ontario had higher prescribing than most of the rest of the province. Here you'll see how this increasing availability of opioids is translated into opioid overdose deaths. And it's a little bit less striking because of the last couple of years changing the scale of the graph. But from 2000 to 2010, deaths related to oxycodone went up 5-fold. And that was really when the public health crisis started to be declared. And it was recognized that opioid prescribing and much wider availability of slow-release oxycodone tablets was leading to an increase in opioid use disorder, diverted opioids on the black market, and opioid overdose deaths. Since 2010, oxycodone has been decreasing in terms of the quantity prescribed and the amount seen on the streets, initially replaced by morphine and hydromorphone, but over the last 5 years, almost completely replaced by illicitly produced fentanyl. And you can see that fentanyl-related deaths now outstrip all the other opioids in Ontario. So having described the problem with opiate use disorder and overdose deaths, I'm going to turn to some research to try and understand the effectiveness of treatment and what we can do to improve treatment effectiveness and respond to this need in the communities that we serve. The data will come from two main places. ICES, or the Institute for Clinical and Evaluative Sciences, is an agency that was created by an act of our provincial parliament. We have universal health care in Ontario, across Canada. It's a provincial responsibility, and so there's a single insurance plan funded by the provincial government that covers all physician services and hospital-based care across Ontario. And the data from that insurance plan and from those hospitals and other health-related data sets are all deposited at ICES, anonymized, and then made available for research. So some of the research that I'll show you comes from ICES data looking at the entire population of Ontario. Other data that I will show you comes from the Canadian Addiction Treatment Centers. During the time frame of these studies, we had 72 clinics across Ontario and 20 pharmacies and about 500 employees. We're now up to about 100 and clinics, 24 pharmacies, and over 700 employees, providing care with methadone or buprenorphine naloxone sublingual tablets for people with opiate use disorder across Ontario. And the map shows you how the clinics are widely distributed, including across Northern Ontario. We have a common electronic medical record. We have a common set of policies and procedures and treatment practices. And by extracting the data from that electronic medical record, we're able to get more detailed information on the patients in care at these clinics than we can from the province-wide data that we get from ICES. So the first study that we did using the ICES data was to look at the impact of geography. We were able to look at treatment retention. So the next series of slides you'll see all have a survival analysis curve showing treatment retention and continuous opiate agonist treatment. Treatment retention is the primary outcome we use, not because the goal is to keep people on medication, but because we know that the longer people are on medication for opiate use disorder, the more that they demonstrate benefits in terms of reduced opiate overdose death, improvements in physical health, improved mental health, reduction in opioid use, reduced crime, reduced use of other drugs, and a whole range of psychological, social, and physical health outcomes that improve with length of time in treatment. And so we'll use treatment retention as a primary outcome to compare different treatment settings and different patient and program factors that might impact treatment outcome. So we looked at geography first, and we were surprised to see that treatment retention was actually better in northern and rural parts of the province than in the southern urban area. In retrospect, that might not have been a surprise because treatment access is a little bit poorer in those areas. And so where treatment is harder to access, the patients who make it into care may be more motivated or may be less likely to have severe mental health problems that have a negative impact on treatment retention. We went on to use the CATC data to look at urine toxicology results and evaluate the impact of cocaine use. Other authors have shown that cocaine use predicts premature dropout from treatment for opiate use disorder. We showed that there's actually a dose-response relationship to this. So patients whose urine was positive for cocaine 75 to 100% of the time when it was tested were much more likely to drop out of care early compared to those who had no or almost no cocaine use. We saw a similar dose-response relationship for benzodiazepines. Patients whose urine were positive for benzodiazepines 75 to 100% of the time had much worse treatment retention and overall outcomes compared to those with little or no benzodiazepines in the urine. In fact, the gap between the 0 to 25 and 75 to 100 group was greater with benzodiazepines than with cocaine. We went on to look at the impact of prescribed versus non-prescribed benzodiazepines. We were able to do this by importing the electronic medical record data into the ICES umbrella and then matching the records so that we could identify whether benzodiazepines were prescribed by any physician in the province, not just the physicians who were working at our clinic and using those EMRs. And so we've showed that only for patients who were consistently positive for benzodiazepines and did not have a prescription did those benzodiazepines have a negative impact on treatment retention. Patients who were prescribed the benzodiazepines did just as well as those who were not prescribed benzos and did not have benzos in their urines. And so it's really this illicit or unprescribed use of benzodiazepines that's a marker for patients with more severe treatment needs and where additional services and supports might need to be put in place in order to improve their treatment outcomes. In large parts of Northern Ontario, there are few or no physicians with the expertise in addiction medicine to provide this type of care. And so a lot of the opiate agonist treatment in Northern Ontario relies on physicians providing care by telemedicine. We were able to look at the effectiveness of telemedicine delivered care. This is telemedicine where the clinic is present in the community where the patient lives and receives care, and the nurses and other support staff are there in person, but the physician comes in by secure video conference in order to see the patients. And we showed very clearly that the patients who were seen most or all of the time by secure video conference did as well or better than patients who received most or all of their care in person. This supports the idea that we should be able to make these types of services more widely available through secure video conference and not be blocked by the barrier of physician availability in these small rural and northern towns. The last study that I'll talk to you about was one looking at patients who received their medication at the clinic, the same location where they saw the nurses and physicians, left urine samples and so forth, compared to those who got all those services in the clinic but went to a community pharmacy to have their prescription for methadone or buprenorphine naloxone filled. Community pharmacy dispensing of these medications has been promoted as making it more convenient, longer hours, easier for patients to access. We were surprised to find a very negative impact on treatment retention of having care in a community pharmacy. And we think it's because they lose all of those touch points where the nurses and support staff can see the patient, assess how they're doing, give feedback to the physician and to the patient about how their care may need to be adjusted. Communication between the community pharmacy and the clinic isn't as good as having the patient actually come in every day early in care and frequently later in care so that we get much closer monitoring. And I'll just come back to the point about the positive impact of that monitoring in a minute. So on the background of the opioid crisis and physicians phoning people at home and providing a script for a full month of medication with no urine testing. So quite a substantial change from the level of monitoring that was in place prior to the pandemic. For the CATC clinics during this pandemic, we have been able to keep all of our clinic sites open 7 days a week. We've reduced the frequency of physician appointments and urine testing in order to be able to maintain physical distancing in the clinics. And so we've had much less contact touch points with our patients, although not reduced to the point of only talking to them on the phone with no monitoring. We've seen only 4 infections, 2 in staff and 2 in patients, and all 4 of those have been traced to exposure outside of the clinic. So it seems that the plexiglass barriers, social distancing, and personal protective equipment steps, along with enhanced cleaning that we put in place, prevented the spread of the virus within our clinic setting. We've seen some negative impacts on patient outcomes. Fentanyl positive samples have doubled from February to May of this year. Cocaine and amphetamine positive sample rates have also gone up. There have been what seems to be an increased rate of treatment dropout and fewer new patients or patients returning. And province-wide, there's no official numbers yet, but unofficially it sounds like overdose deaths have gone up about 25% in the last couple of months. So I'd just like to close by acknowledging my collaborators, fellow faculty members, postdoctoral fellows, graduate students, and research assistants who've made all of these studies possible, and the funding that we receive from CIHR and NOAMA and other sources. Thank you, and I look forward to the discussion.
Thank you so much to David. David is struggling with his video, so he's gonna keep trying to fix it, and if he can, then you'll be able to see him momentarily. Given us so much to think about, what's really encouraging on our end is that telemedicine is certainly now sanctioned by the HPCSA and has become a lifeline really for many in need. Our own clinical services within the Division of Addiction Psychiatry have been using versions of telemedicine to continue providing services for those who are accessing opiate substitution therapy, for example. It's also promising that the SA health sector in general is engaging more actively in the space of medication-assisted therapy. And certainly now with COVID, there's going to need to be modifications to those plans that are responsive to the challenges and the lessons that we've been forced to learn under COVID. Question of what does social accountability really mean in our context, particularly considering some of the structural challenges which have been alluded to by Bronwyn earlier about those mandates from varying sectors which don't necessarily speak the same language. How are we engaging with service users in our communities? Are our interventions targeted correctly? Is our academic interest in treatment retention and specific outcomes missing the boat? How do we fix this? I think certainly one way to think about it, and I think it was fleshed out in David's presentation, is the need for interventions and outcomes to be really mapped to the community's needs. In our context, trauma is a significant such link, and it's something that we understand has resulted in much morbidity. And currently, South Africa is dealing with the resurgence of the gender-based violence epidemic in the midst of the opioid crisis, of the COVID crisis. So how does intergenerational trauma really feature in our thinking? And how do we sort of take forward our interventions to meet these challenges? So our next speaker is Dr. Teresa Marsh, who is originally South African and immigrated to Canada in 1992 to continue to contribute towards healing approaches to overcome suffering, trauma, addiction, and historical trauma, particularly in the aftermath of oppression. So we're really pleased to welcome you back, Teresa, back home, even though it's only by webinar. We missed the opportunity to see you here in March. Dr. Marsh has 25 years of experience working as a psychotherapist and a spiritual healer, as well as 17 years of working on reserves doing healing for trauma work using a number of methods, including seeking safety, a therapy developed to really help those with trauma, substance use, and post-traumatic stress disorder. So I'd remind you again that Prof. Marsh's talk is available in the panel should you wish to take a look. So we thank Dr. Marsh for preparing this presentation for us. Here we go.
Good morning, everyone. It's early Monday morning, and I decided to come and sit on my favorite spot here on Lake Ramsey. It's very close to my home. It's really beautiful. It's a huge park called Bell Park. And in the background, people are walking. There's a walking path right around this lake, almost right around this lake. And it's a place where I come and sit when I need to refuel. And I thought this would be a good place for me to talk to you today. So in North America, in Canada, when you are an Indigenous researcher, clinician, and you start your presentation, you have to, as we say, situate yourself, who you are, where you're from, where you're at. So my given name is Teresa Nasiba, and I work mainly with the Indigenous peoples here in Canada. So 2 years ago, the elders that have been teaching me about the Indigenous way of being, they gave me my Ojibwe spiritual name, and we all have a spiritual name, they say. So my spiritual name is Makanakwe, Turtle Woman. And the Indigenous people here, Canada to them is Turtle Island. I'm wearing my beautiful African Indigenous outfit, and I always wear my African clothes, and this is how I identify. I never ever want to forget where I come from and where I've been. I just want to thank Lionel and Goodman and everyone else for putting this, for making this happen. And I feel honored today for being able to be a part of this conference, looking at what we can do as we move forward during COVID-19 and this pandemic. So I also included a set of PowerPoint slides, and the last slide, my website is on there, training website, and also my YouTube address. So it's all available to you. There's no password for my website. all my published papers and what I'm going to talk about, and authors I'm going to quote today is it's all there. So use whatever you can use. My gift. Yeah, so my mom was indigenous South African. My dad and his ancestors, they came from Indonesia. And I left South Africa in 1992. It was a difficult time for all of us, but my soul was tired, my soul was exhausted. I was a single mom and 2 daughters and a son, and we left for Canada. We landed in Toronto, and I was a registered nurse, registered midwife, and psychiatric nurse at Groote Hospital. So I started working at Mount Sinai, and that's where I met Dr. David Marsh. We've been together almost 26 years now, my soulmate. We're doing more or less the same work, just trying to make a difference in this world. But I must say, when I came to Canada to heal, I can't imagine, I could not have imagined the amount of stuff that I've stuffed away. That's how we dealt with it. We never talked about it. The atrocities, the colonization, the apartheid, the rapes, the sexual abuse. I was abused at age 8 and all the rest that goes with it. My soul was exhausted, and I just thought I could maybe as a single mom do something different for my children. I miss my mother country. And when I connected with the indigenous peoples here, I realized they had a similar history. Horrific what happened to the first peoples here. Horrible. And as I started working with the indigenous people on the reservations, helping them with the intergenerational trauma and addiction, I thought, wow, this is what happened to us as well. I understood, and I connected with them, and they connected with me. I love the First Nations people here. My family. But coming to Canada was the first time that I met the term intergenerational trauma. And Dr. Daniele was the first researcher who looked at intergenerational trauma in her research with the Holocaust survivors. And the grandchildren of the Holocaust survivors and those of their grandparents that were in the concentration camps and endured horrific trauma and deaths and torture. These kids exhibited the same symptoms, but they were not in the concentration camps. From there on, Lakota social worker, indigenous social worker, Dr. Maria Yellow Braveheart, she looked at her people and how they were using substances and hurting each other and hurting themselves. And she started her research, and then she termed it historical trauma, intergenerational trauma, and then other beautiful indigenous researchers and all of these authors, and they are in my reference list in my research work. Dr. Wesley Eskimo, Dr. Teresa Campbell, Dr. Eduardo Duran, and Dr. Eduardo Duran, he talks about what has happened to the people, or intergenerational traumas, also a soul wound. It's a soul that also gets injured. And so working with the indigenous people and understanding intergenerational trauma better, I could see that, yes, that is what is happening, that it's passed on from generation to generation, particularly the indigenous peoples that ended up in residential schools where they were sexually abused when they came out. How could they be parents? You know, when we are locked up in our trauma or in our intergenerational trauma, we start hurting ourselves and we hurt others that look just like us. But that also comes from internalized oppression. And internalized oppression is connected to intergenerational trauma, because internalized oppression can only be played out in two ways. One, we begin to hurt ourselves. And do we see that in our people every day? With the substance use, with the addiction, with the hurting each other, with the violence, with the rape. Every day we see that. The racial profiling. We hurt ourselves and we begin to hurt others that look like us. And the work that I did with the indigenous communities was about conflict resolution. They were hurting each other. The leaders were sometimes oppressing the people, as it happened in South Africa as well. But, you know, I believe that we are born to heal. We are born to heal. This is the medicine wheel. And I give this to all my clients and people that I work with. Doesn't matter how deep the trauma. I've healed when I came to Canada, my traumas, my abuse. And so did my children. So it might seem to you that I'm talking about the there and then, but I'm actually talking about the here and now. Because the whole premise is, what are we going to do about now as we move forward? Because now we see that the COVID-19 and the lockdown is either bringing out the best in people or the worst in people, and it's connected to the trauma. And when I look at trauma and define trauma, I say it's too much, too fast, too soon. And trauma causes that disconnection. We disconnect from ourselves, we disconnect from families, friends, our system, our soul, our body. Everything shifts and changes within. And Dr. Kabur Mate did a lot of work on the downtown east side with addiction, and he said it's not the addiction, it's the trauma. It's the trauma. He says I see people hurt themselves, they lose their teeth, they lose their limbs, they get sick, but they keep on using. So it's the trauma. And we have to focus on the trauma. So then in 2003, Dr. Lisa Najewitz launched the first treatment manual called Seeking Safety, Treating Trauma and Addiction Integratively. So for my PhD research, I took the work of Dr. Lisa Najewitz, very well researched, got over 40 empirical studies. I took her work and I incorporated indigenous traditional healing practices to that model and created a hybrid approach, or I would say the concept of 2IC. And I offered it to 12 Aboriginal men, 12 Aboriginal women. I used a mixed methods approach, qualitative and quantitative inquiry. And I measured it using trauma symptom checklist 40, the ASI addiction severity index, but I also used a historical loss and historical grief scale, asking people, how do you feel about loss of losing your land, losing your culture, losing your language, being oppressed, and the outcome was phenomenal. Dr. Lisa Najewitz's Seeking Safety model offered 25 sessions, and Lisa never left a stone unturned. She looked at everything that's ever possible in the person experiencing both trauma and addiction. So we teach them about their trauma and their addiction, and for every session they get a handout and they get tools that they can take with them and utilize to help them heal from their trauma. And the participants in the study, they were astounded. They were like, oh my gosh, I never knew this. Because both trauma and addiction, I told all of them, it's a no-fault disease. It was not your fault. Nobody asked to be traumatized. But we are not responsible for being down, but we are responsible for getting up. So how are we going to get up? How are we going to get up? How are we going to do this? And you can do it, because nobody can help you heal from the trauma and come home to your embodiment. Because healing from both intergenerational trauma and addiction, it's coming back home to this vessel. The trauma is not in the story, not that the stories are not important. Trauma's in the brain and the nervous system and the embodiment. So we work with people somatically. And I wish I had more time, but you know, the time it's really, really short. But when I look at what can we do for the indigenous people here, the reclamation process was very, very important. I mean, there's a movement now where they're claiming back that which they have lost, you know, their spirituality, their being connected to the land. Ceremony, and in ceremony, the types of ceremonies it's prayers, it's fasting, it's sacred dancing, sacred drumming, all of these things they're bringing back. And all of this has helped them during the study. Speaking with elders, all this time I've been so fortunate, and during the time doing my research, my elders just taught me. They just kept on teaching me, and you will read in my papers how this research happened and how it helped so many. At the moment, I'm just going through all the indigenous communities, and I've created a curriculum. It's a 5-day training program where I'm training frontline workers and healthcare professionals to become trauma informed. And if we are not trauma informed and we don't understand the interrelationship with both trauma and addiction, yes, we are going to fail. People are going to be, say, stuck in their trauma. But this is where we need to go, right? And a lot of people that have gone through their healing, that have healed from addiction, and that they are people that we can train, frontline workers, to helping other people heal, helping youth. We can train youth, helping youth by giving talks, you know, by being active. That's what we need to do. And for us as healthcare professionals, I mean, I really just want to end saying that we have to join hands. Like, I was going to come to South Africa, as I said, and I had a 2-day workshop lined up with frontline workers and faculty at University of Western Cape to give people this training. And I want to come to South Africa and give people this training. And I hope that we can collaborate. I hope that we can build partnerships through NASM, that we can make this happen. I will come gladly anytime to talk more about this and to do the training and to train the trainer, because this really, really, really works. But safety and self-care for everyone, safety and self-care for us, it's very, very important. I think I'm a very good timekeeper without looking at the clock, and I'm thinking I maybe have talked more than 20 minutes, but I want to also just say to all of you that what has helped me in Canada and what is helping the people here is having the social determinants of health in place. What is that? It's acknowledgement of people and where they at, and acknowledging people and at all different levels, disabilities to do more for in that capacity, early life, to do more in childcare and maternal care, education, employment and working conditions, food and security is very important, and of course health services and gender identity. And I guess I could add also that whole notion of zero tolerance to violence. I want to end by a quote from my Madiba, and I hope that for our children and children's children that we don't have to say this at a later time. But he said, the millions of graves strewn across Europe, which are the result of the tyranny of Nazism and the decimation of the native peoples of North America, the Americas and Australia, and the destructive trail of apartheid regime against humanity. All these are like a haunting question that floats in the wind. And the question is, why did we allow this to happen? And I can just say to let our children not ask us this. And this COVID virus, yes, it has brought out a lot of stress, but there's a lot of positive things that we can do right now, like this virtual conference. I mean, we can do many of this. We can. So thank you, everyone. I'm looking forward to the discussions and the questions. And as I say again, all this information is on my website, traumahealingguru.com. And also I do 5-6 minute talks every day during this pandemic, and just talking to people. It's helping my clients and just giving positive words there. Thank you so much, and looking forward to meeting all of you in person. Chimikwich, meaning in Ojibwe. Thank you.
Thank you so much to Teresa for putting that together for us. Really, at the core of so much disruption that's happening in the world today is that sense of loss, that loss of land, loss of culture, loss of language. And how then do you come home to the vessel, having to navigate that divide? So thank you so much for such an interesting conversation. Coming up next will be our three panelists from University of Cape Town. I'll switch on their videos momentarily. It's going to be Ishak Gatai, who's a senior lecturer in the UCT Primary Health Care Directorate, Zarina, who's a clinical educator for the Department of Health and Rehabilitation Sciences, and Paul, who is a registrar in the Department of Psychiatry and Mental Health. So Ishak, you're going to go ahead first. Thank you. Seems that we've lost Ishak temporarily. Perhaps Zarina, you could go ahead, and then Ishak, when he reconnects, can go ahead for us. Is that okay?
That's fine.
All yours.
Hi, everyone. I just want to share my screen quickly. Am I good? Okay, so much of my presentation here is from an OT perspective, integrated with my background of mental health and addiction care. Sorry, I'm just struggling here with. So before considering community approaches, the experiences of people in communities needs to be contextualized. At the center, I've situated the intergenerational trauma being discussed here today, because you think of a generation of people whose current lived experiences mirror previous experiences of inequalities in our history. How is this influencing the addiction care landscape? The surrounding factors I have here expose these traumas even further, because these experiences are deeply embedded in the histories of the communities we work in. The context might be different, but the emotional responses might very well be the same. How does COVID-imposed restrictions like what I've listed here make communities feel? These inherited traumas have the potential to bring conscious what was dormant for a very long time, because they echo previous experiences of injustice that have been marinating in the generational memory of the communities we work in. You think of a young child or an adolescent who's absorbing all of this. Does this increase susceptibility of communities to the development of occupational engagement difficulties, and perhaps the use of substances as a means of coping with these experiences? As OTs, identifying vulnerabilities in communities means looking through the occupational lens. Occupations are about people's meaningful engagement in what brings them purpose. The current loss of roles, disruption in occupations and routines speaks to the occupational injustices in their already very vulnerable states. The theme of isolation is consistent in the field of addiction, and seeking connection is meant to be a voluntary entry into a recovery process. COVID-19 has snatched away that autonomy. We go back to the intergenerational trauma that's causing extra stress, now raw and exposed. It's almost like a re-trauma, and we think about how it's influencing addiction care planning. This particular act makes provisions for strategies in terms of services, and community-based programs form part of this. Community programs or community approaches are situated in the different phases of the recovery process, but we need to re-look at how services are aligned. We have to remember that service providers and service users are both at the mercy of restrictions at the moment, and both sides are feeling very vulnerable. If you think of platforms like schools and primary healthcare, for example, these are now compromised, and this is often where things like preventative strategies are situated. So support and integration is also in jeopardy because of the pandemic. So our response as healthcare providers needs to resonate with empathy and accountability in terms of the services that we choose to provide, addressing the needs of the communities and they identifying those needs. The landscape has changed, and so community approaches, in my opinion, are crucial because they are the catalyst for the connection that people seek. We therefore need to think about providing spaces for reaching out in terms of that connection in this changed landscape. I've pitched some ideas here about community approaches with regards to addiction care. If we look at frameworks like PSR and integrating community reinforcement approach, even health promotion, we need to think about how substance use disorders are situated within the COVID crisis. If these are based on principles like creating supportive environments, how is this going to be implemented with current restrictions? PSR also talks about the potential of people to grow and the significance of skills development. I believe that education and skills development go hand in hand in terms of continuum of care and ongoing support to those in the community. We need to empower people in the communities to take ownership and take back the lost autonomy, because this is a very important step. Things like contingency management is based traditionally on positive reinforcement and extrinsic reward systems. OTs use the concept of engagement in occupation as the reward itself when considering lifestyle changes associated with substance use disorders. So how can OTs contribute to addiction care program planning in terms of things like occupation-focused groups, for example? Risk assessment that's previously being done in more clinical settings can be integrated into community approaches so that we can identify vulnerabilities in communities. How can, for example, community rehab workers trained at disability studies be equipped with skills to consider things like a risk assessment that's being done in the community without compromising scopes of practice, but rather enhancing interprofessional collaboration? Other strategies I've suggested include gender analysis, considering culture and spirituality, as well as family interventions within communities. I think these are aspects that need to be considered further when planning interventions that are based in the community. Thank you.
Thank you so much, Zarina. So next we're going to go to Ishak. Ishak is going to take us through his response to today's presentations. Thank you so much, Ishak.
Hi, good afternoon. Thanks for inviting me. It's an honor and a pleasure to be here. I just want to double check that you are able to hear me before I carry on talking.
We can hear you, Ishak.
Okay, great. Thank you so much. So yeah, so I've been asked to respond from a comprehensive primary health care perspective with regards to substance use. And when it comes to primary health care, it means different things to different people. But from the perspective of comprehensive primary health care, for me, it refers to the Alma-Ata Declaration and the principles of the Alma-Ata Declaration. And from my reading into social accountability and comprehensive primary health care, there's a lot of overlap between the two concepts. If you don't mind showing the slide, please. So for me, the term comprehensive primary health care, when I think of it, actually refers to health for all, which was the slogan of the Alma-Ata Declaration. And what we've done at UCT is we've taken that slogan and we've created a mnemonic for the different principles of primary health care. And I'm going to speak to some of these principles, and certainly in some of the presentations before this, a number of these principles have been alluded to. So the issue of accessibility to care, the issue that substance abuse is very strongly rooted in issues of human rights and equity, and then of course the fact that when it comes to thinking of a primary health care approach, we actually have to think of care at every level. Not just the primary level care, and often when people think of primary health care, their thoughts of primary health care is limited to care that happens at the primary level. And I'm going to speak to what does happen at the primary level as well. And kind of preparing for these few minutes, I've spoken to family physicians, mental health nurses, addiction experts, social workers, and academics, and just to get their view in terms of the lay of the land with regard to substance use in the context that we're living. So the one challenge that we've got is that addiction is seen as a social problem and not as a health problem per se. So the funding for addiction goes primarily through social development. There is some funding through mental health, but a large part of the funding goes through social development. And there's a big stigma that comes with addiction. The family physicians that I've spoken to, they say that the involvement in management of people with substance abuse is minimal, except for the Eden district in George, and I'll get back to that. But essentially what happens, and the context that I see patients, I often see them in the acute presentation, or if they're non-adherent to TB or HIV treatment, or often in the trauma setting, where and the trauma epidemic was alluded to earlier as well. And I've also seen patients in prison medicine, where often people are in prison because of the addictions. And in the community work that we're exposed to, we see how structural violence really it kind of embeds this challenge within the communities that we face. But through all of these referral pathways, they get referred to the mental health system, where they get screened, and then from there they get referred to a social worker, where they can get either inpatient or outpatient treatment. And there's a number of treatment options available within the Western Cape. There are faith-based organizations where patients can get referred to. There's the Matrix program, which is run by the City of Cape Town, clients get addiction counseling, and they also have job placement, and there's been a significant growth in the past 10 years in terms of skilling of social workers to deal with mental health issues. There's the diploma in addiction that's being run by Stellenbosch University. So there's been growth in terms of management at the primary level of care for people with substance use challenges, but there are also major gaps in that. So the big gap is the collaboration between social development and health, and there's a lot of disjointment at that level at the moment. There are also challenges with regards to access to pharmacological treatment that can be used to assist people with substance use challenges. And then also there's also a big challenge in terms of research. There's not enough research that's happening with regards to substance use. And these are kind of all the downstream factors or addressing things at a downstream level, but we also need to look at an upstream level. You know, how do we address issues of equity? How do we gain greater intersectional collaboration? Now, I just want to speak to a couple of positive, more positive examples as well that we know is happening. And Dr. Herman Ritter and other doctors in the Eden districts are quite involved in projects such as the Sahara project, where they are trying to get pharmacotreatment for people with substance use challenges. And they're also involved in things like youth programs where they're trying to look at preventive strategies. But in terms of actual policy that's in place that deals with the challenge at a comprehensive level, it's not really happening at this point in time. There's opportunities for community participation, and the COVID kind of epidemic has kind of shown that we community health workers are kind of doing more community level work, and that can be strengthened. But in the long term, we actually need to look at how we can make substance use, addressing the challenge of substance use, a greater priority. And we need to think about movements for change, creating something like the TAC for substance use. And we need to think of a whole society approaches. We need to think of 20, 30, 40-year kind of objectives in terms of dealing with this challenge. But thank you for your time, and thanks for this opportunity.
Ishak, thank you so much. We're asking so much of you, asking you to distill so much detail in such little time, and we really appreciate what you've been able to put together so quickly for us. And certainly there will be additional opportunities to engage on more of these issues. And Paul, won't you come and sort of bring us up to speed about where you're at as a new clinician in training, and tell us, you know, what's important for you. There you go. Now we can hear you.
Okay, that's all right. My apologies. Thank you. Thank you to the organizers for inviting me to be a part of this panel and this very important discussion. So my contribution will be a reflective one. So I grew up in Gahiso, a township just west of Johannesburg. Next was UCB. So each weekend morning, we would be witnessing intoxicated adults staggering their way home, and that's not if they were passed out in a stupor just on the sidewalks. These experiences formed my early ideas around addiction, that being a disease of the weak and those without dignity. These views were solidified by my strong religious and moral upbringing, essentially terming alcoholism and addiction in general a moral disease. When I got to medical school, I was taught about the biological basis for addiction. This was a scientifically sound and acceptable explanation for me, and I would carry on using it during my time as an intern. After internship, I went on to work in a psychiatric hospital in the Northwest. It was for the first time that I independently cared for people's psychiatric illnesses, and substance use disorders formed a large part of our disease burden. It was here where I learned how to explore the narrative beyond the substance use. Our hospital provided a 4-week inpatient substance rehabilitation program, and qualifying adults were those who were referred by the Department of Social Development, those with dual diagnoses who were identified in the wards, or those who were ordered by the courts. It was quite exciting to identify patients who wanted to attend this rehabilitation service, as it did form part of our long-term treatment goal. Of course, some could not attend because of other reasons, like perhaps poor job security, those who had to go to school. I had read in literature and noted that substance use is associated with a high relapse rate. This did not prepare me for the many readmissions that we had, including from those patients who did attend the rehab program. So I went back to the literature and I read to see if I did anything wrong and how to fix this. And as I was doing this, I was giving a tutorial to a group of medical students, and we were speaking about psychosocial determinants of mental health. I began relating this to substance use, and I had an aha Oprah moment. In that moment, I just realized that South Africa is a violent country, that South Africa was born out of the humiliation and dehumanization of Black people as defined by PIGO. This violence continues to this day, and we see it at the moment playing out in gender-based violence and femicide, and rape, and indeed addiction. I opened myself to the reality that addiction is a response to a hurt, broken, and traumatized society, as Dr. Marsh and others explained earlier. And that the healing work has been abdicated to other people, whoever those people may be. And that unless this work is done, we will continue to treat our conscience and mistake this for treating our patients. COVID-19 has showed us that the things that we were told were impossible can be done. We've seen hospitals being built and capacitated within a matter of days, social relief programs that have been improved and been made available to those people who need them, small businesses that have been assisted, just to list a few. So then there is no reason why we continue to defer this hard work of repairing our broken society. Of course, COVID-19 and the lockdown itself has been a very stressful time. Many people have lost their jobs. Some find themselves homeless. Others confined to solitude. People are coping as best as they can. Though I am unable to provide figures, some anecdotal evidence seems to suggest that there really has been almost like a steady number of substance-related admissions to pre-COVID times. But of interest is that we've also noticed that there's a lot of relapses that are coming in, perhaps a response to this stressful time. So with I think those few words, I look forward to further engagement, learning and growing in the field, and using the skills and knowledge around social accountability and intergenerational health trauma, in the daily healthcare provisions and interaction with patients that I'll be involved in. Yeah, thanks.
Thank you so much, Paul. I appreciate you taking time to give this some thought. So we're getting close to the end, and if Prof. Green Thompson can come in and give us some closing words and reflections on today's session.
Is Dan coming online?
No, we just want to save some time, so we've opted to go straight to you, Prof.
Siyabonga kakhulu, Nkosi. Thanks very much for all the contributions that have come through today. It has been a time for me of reflecting now, having prepared some words to say at the end of the session, just being struck by the many lessons that I've received again through the many presentations today. There are a couple of things that I want to emphasize in terms of the theme that come through, the themes that come through. I want to just, and I will just raise them in phrases, and then I'll try to bring them at the end. This notion that context matters, that where we are and what people are in is often determined by our context. And our context is a particular one today because we're on the back of the celebration of the June the 16th uprising. And I say celebration because it was that expression that emerged from many generations that have come before trauma. So even as we remembered yesterday, I think I'm not sharing mine. Even though we had a sense that we had a sense in the celebration, in the commemoration of yesterday, that we were thinking about those who had gone before us, who had been killed in the pursuit of a just cause. I mean, those many people that, in many ways, our reflections on the day come through in this notion of people die so that something greater can come out of that. So I want to just, in terms of the issues that I think came up today very powerfully, that context matters, that in David's talk, the notion that we can make a difference is crucially important when one thinks about social accountability. That if one looks at the evaluation, the NETS evaluation framework, that's a key part of what we do, is that we need to make a difference. But the question then becomes, what difference do we make? And there were a couple of things in Teresa's presentation about the intergenerational trauma. This shifting from a quantitative approach to a qualitative approach, I think, is a really, really crucial conversation that we must have, that we begin to see just how, if we move from counting things to accounting for things in a qualitative space, it shifts the way we think about a particular problem. And I really want to thank both Teresa and David for their reflections, both from a quantitative perspective and a qualitative perspective. I was quite struck, given that I come to the space essentially peripheral to the discipline I'm from. I was quite struck at Bronwyn Myers' reflection that our problems, the burden of disease in this area is much higher than I had expected it to be, and those numbers that she presented were quite startling. In particularly, the gap between those who have a problem and those who are accessing care to any great measure. I want to thank the UCT respondents, because I think they captured quite well the essence of what we're trying to do in this conversation. To Zarina Syed, thank you very much for that notions of the fact that in terms of our health care, accountability and empathy should be the two sides of a coin, that we can reflect on the way we take care of the patients who come into our spaces. The notions of community rehabilitation is quite a fundamental idea in how we empower communities to engage with the process of caring for the people amongst them, because essentially not all the people are patients, but they're all people in need of care. To Ishaq Date, the thing I've been taking away this afternoon, I'm not sure where the main camera is. Let me see if I'm looking at my camera. I'm not quite sure why it's got me on the side, though. I really don't know what's going on, but yeah, I'll have to look at that. Okay.
Oh, good.
I just can't work out where to look from where I am. So the idea of changing addiction from a social problem to a health and well-being issue that needs to be attended to, I really think is quite an important thing for us to engage in. Oh, I think I might have found it now. It's on my laptop. Okay. So I think that it represents an important shift in the way we think about this problem, because it is a thing that, and I quite like what Paul said at the end, the notion that we've treated this as a disease of the weak, a moral problem. And I appreciated his journeying from that position, which is often a moralistic view, to one in which we regard it as something that the patient comes with, and therefore something that we have to treat effectively. He also challenged this notion that we should be treating our patients and not our conscience. So, colleagues, what has happened for me today is that I have come into the conversation with the particular framing of both the topic and its connection to social accountability. But I'm leaving with a reaffirmation of the focus of what a health science faculty should be. It is about bringing different voices into the room. It fascinates me that Teresa has had to leave the Cape Flats to go to Canada to experience the healing that she speaks so eloquently of. And that's part of the journey of a faculty like ours. So what addiction has meant for me in preparing this thing together with Goodman is this notion of you take a subject which is really part of the high science of the faculty, the psychopharmacology, the study of genetics, the study of the chemistry and pharmacology of the problem. And today has allowed us to reflect on the full spectrum of engagements around this. We've brought in different professions, we've brought in different perspectives, and hopefully this becomes a mark of the conversations we have in the faculty going forward. I want to thank Goodman Sibeko particularly for his preparation of today. I think you structured the day significantly in a way that we could all engage with it. And I want to thank Professor Dan Stein for engaging with the idea when I first broached the idea before I arrived. David and Teresa were supposed to be in Cape Town in the first week that I came into this job, and I had hoped that this would be our first conversations in that period. So tomorrow will be exactly 3 months to the day of the last plan that we had to have this workshop. So I'm deeply grateful that it has come together in the manner that it has. Yesterday, we took the opportunity in the faculty to launch a transformation framework, and a transformation framework which calls us to engage with each other differently. And one of the things I said in the statement yesterday, and I want to repeat that here, is that there are few conditions in our disease compendium that will need this approach more than addiction. And it's my call to all of you participating here, and particularly in this COVID time, because it may be the thing that you do to yourself as much as you do to other people. We need to listen with compassion, to walk with humility, and to act with justice. Enkosi kakhulu.